Thank you. Share my screen. So we're running on time, which is remarkable in my experience. Today I want to talk about radiation therapy in general for glioblastoma, but I am going to focus not solely on conventional or photon X-ray based radiation, but more specifically on proton-based radiation, which is not a new form of radiation, but it is an uncommon form of radiation. So I would argue that for glioblastoma, and indeed for any other tumor type, the standard radiation modality, the standard radiation treatment in the US and anywhere else in the world is photon-based therapy. So with photon-based therapy, we are using linear accelerator to deliver high energy photons to the patient. Photon therapy, in comparison to protons, is sometimes viewed as rather simplistic. However, that is certainly not the case. A new state-of-the-art LINAC is capable of advanced radiation delivery using techniques which we term IMRT or BMAT, in which the radiation beam is shaped specifically around the tumor using advanced MMLCs or little multi-leaf collimators within the head of the machine. What we do with this sort of radiation modality is to deliver high doses of radiation to the tumor, shown on your right in red, with some lower dose radiation, which is unavoidable with photon-based therapy, spreads to other parts of the brain. So why would one be interested in proton therapy? Protons, it is a particle radiation as opposed to photons, and that mass allows us to stop the protons at a pre-specified depth within the patient. For example, just beyond the brain tumor, we may stop our beam there and not expose any normal tissue beyond that area. So realizing this, in our initial thoughts on proton therapy, we have always sought to reduce side effects for our patients. I'll reiterate that we currently have not looked to dose escalate or improve tumor control, but instead our main goal with proton therapy has really been to reduce side effects of radiation therapy. Why does everyone not have a proton therapy unit? It is very costly. It requires an institutional commitment monetarily. This is a picture of one of our gantries, which is the machine that rotates the beam around the patient, directing it into the room. We have 3 gantries at MD Anderson. One is shown here with the red arrow pointing to an engineer standing below it while it was still being constructed in the Hitachi facility in Japan. This gantry weighs essentially as much as a 747 airplane, and so it really is a massive undertaking. And unfortunately, for better or for worse, this does get attention, sometimes negative attention, with the thought being that maybe we are driving up healthcare costs by using these large, expensive machines without really knowing what the benefit is. When we initially started with proton therapy in 2006 at MD Anderson, what we did was look at these dose distributions. On your left is the photon dose distribution, which I'd shown before, the high energy X-ray. On the right is the proton dose distribution, and you can see that we've taken away that low dose radiation, which is in blue and green, and the whole other side of the brain is not exposed to that. And so from a radiation oncology perspective, what we first said was, the Herman Suit very famously said, you cannot have a radiation-induced side effect in a tissue that does not receive radiation. So first principles, give dose to the tumor, but not with normal tissues. This is why we started to build proton units. However, especially here in the US, where we are under some financial constraints with our healthcare system, folks began to ask, well, where is the evidence? How can we prove that protons are actually better for brain tumors or any other tumor? And the answer is it takes time to develop this evidence. The first proton center in the US actually opened in 1990 in Loma Linda, and there were no others for years. And it was really only in 2006 when we came online, when there was a start of an exponential growth in the number of proton centers throughout the US. So with only a few centers, obviously you're not treating as many patients in the US. In 2006, there were probably 2,000 to 3,000 linear accelerators of photon-based machines operating, with only 5 proton centers operating. So you can see the patient numbers are not going to be large. It also takes time to design the study, treat the patients, follow up, analyze the data, and publish the data. So I'm going to try and give you some of the evidence that we have gathered in the last decade or so. So just to reiterate, we opened our doors in 2006. We were the first proton therapy center to use what we call spot scanning or pencil beam proton therapy, which is the most advanced delivery form of proton therapy. We have a very active CNS, adult CNS, as well as a pediatric program here at the MD Anderson Cancer Center. So who are the adult central nervous system tumors that we treat? I do treat a lot of chordoma and chondrosarcomas. These are require very high doses and typically favored using a proton therapy approach. But the actual largest number of patients we treat for adult patients is glioma patients, including glioblastoma patients on occasion. So as we've heard, the pathology is really changing in the past decade as we learn more about what is driving these tumors. Initially, one of my colleagues from Helen Shih looked at the use of proton therapy for low-grade glioma, patients that may have a favorable survival, and so they said, well, if less is more, then we should treat these patients. Why would we do this? We know from photon-based therapy that even low dose to the hippocampus or other brain structures can be associated with cognitive impairment. This is a study from a colleague of mine, Vinay Gandhi. This was done in primary brain tumor patients with low-grade tumors, and they were able to show that even doses as low as 7 Gray, so your prescription dose may be as high as 60 Gray, but doses as low as 7 Gray to the hippocampus can be associated with cognitive impairment. He's gone on to extend this study, and it's all you are probably well know that it was also done for brain metastasis patients, a trial of hippocampus sparing, which did show a benefit to memory preservation if you do spare the hippocampus. So following up on these low-grade tumors, an initial single-arm study, the outcomes were very, very good for proton therapy for these low-grade tumors. If you tested these patients years after radiation, they essentially had no change in their intelligence quotient. They had no change in executive function, memory, or attention problems. Seeing this, the decision was made by Dr. Paul Brown, who was at that time here at MD Anderson, to try proton therapy for glioblastoma patients. And this was actually remarkably done in a randomized phase 2 study in which patients were randomized to either the pencil beam proton therapy or modern photon intensity modulated photon-based therapy. The primary hypothesis was that protons are going to preserve cognition by sparing essentially the contralateral half of the brain, sparing the contralateral hippocampus, frontal lobe, what have you. The sample size was powered at 80, and it was difficult to accrue. Honestly, a lot of the difficulty came in terms of seeking insurance approval here in the US for protons for glioblastoma. But with time and perseverance, we did fully accrue this trial. And just recently, it has been published online now only in the Journal of Neuro-Oncology. So hold your breath. What were the results? Again, we've built a very expensive proton center and looking to spare cognition. What we found is that this trial was negative. There was no benefit of proton therapy in sparing cognition in patients with histologically confirmed glioblastoma. So at first, this was likely disappointing to many of the study investigators, but you have to ask yourself, well, why would this be? And it really has to do with the biology of these tumors. A lot of times, patients or other practitioners will blame radiation for cognitive induced deficits. However, the main driver of a cognitive deficit is actually the tumor itself. And the more aggressive the tumor, the more likely you are to have a patient with cognitive impairments. As Dr. Fuller so elegantly explained, we are now looking at IDH status, of course, as well as many other things. This is work from Jeff Weffel here at MD Anderson. And what they were able to demonstrate is that if you look at patients with either IDH nativo or IDH mutant tumors, you can see differences in terms of cognition, with the more aggressive IDH wild type tumors having association with worse cognition in these brain tumor patients. So that begs the question, if this, reducing side effects is really not working out in terms of cognition, can we actually deliver more dose to the tumor and thereby improve disease control for glioblastoma? I won't present these, but there were actually, before IMRT or VNET, the really modern photon-based therapy, investigators at both Harvard Medical School as well as an institute in Japan did use protons to dose escalate for patients with glioblastoma and had some favorable results using protons to dose escalate, in certain cases up to almost 90 gray, with your standard prescription being 60 gray. This prompted the launch of NRG-BM001, which I want to spend a few minutes on. This is a randomized phase 2 study for newly diagnosed glioblastoma patients. It is not a study that randomizes protons versus photons, but it does allow you to treat with either protons or photons. And what it does is within those individual arms, it looks at dose escalation. So you are randomized to either standard dose 60 gray or escalated dose 75 gray, treated with either photon or proton radiation. It's an ambitious study and includes many secondary measures. The results have been published or at least presented for the photon arm, which is fully accrued. The NRG accrues quite rapidly for glioblastoma patients, and this arm closed rather quickly. And in the initial analysis, unfortunately, it was not significant, but there was, a hint of a difference in terms of overall survival, with your standard 60 gray leading to a 16.3 month overall survival versus the dose escalated 18.7 months, but still not significant on analysis. However, the proton arm does continue to accrue, and we are hopeful with those added patients, maybe we'll see something different. So what other factors are associated with poor survival? For numerous tumor types, we as radiation oncologists have largely ignored radiation-induced lymphopenia. We've often blamed it on chemotherapy, in fact. However, what we're realizing now is that our therapies really are associated with profound lymphopenia, and across disease sites, histology agnostic, lymphopenia is associated with poor survival. And this has also been shown over 10 years ago now to be the case with glioblastoma. With a CD4 count less than 200, the outcomes are much less favorable for glioblastoma patients. This is also associated with radiation dose to the brain. And when I say radiation dose, I mean low to moderate dose. And so doses at or below 25 gray, which you can see would be delivered in the photon plan, that is associated with an increased incidence of radiation-induced lymphopenia. So what we did was do a secondary analysis of the randomized trial that was done here at MD Anderson. Again, this was a randomized trial of protons versus photons. And we just recently published this in Neuro-Oncology. And what we did see is that over the course of treatment, our patients treated with protons are much less likely to have radiation-induced lymphopenia. If you summarize it by grade, you can see that clinically relevant grade 3 lymphopenia is much less in our patients treated with protons. Unfortunately, we haven't been able to correlate this with a survival outcome, but that's solely because the power used to for the calculations on this trial was for cognitive outcomes, not overall survival. But this brings up an important point. As we all know, immunotherapy, initial forays into immunotherapy have been fraught with challenges in glioblastoma. And this is, for a multitude of reasons. Immunotherapy, GBM may be a cold tumor or may have an adaptive or intrinsic resistance. However, immunotherapy started in melanoma with great success, has gone on to non-small cell lung cancer and other less immunogenic tumors, and it will come for glioblastoma, I do believe. And in that setting, maybe proton therapy will help reveal the benefits of immunotherapy. If we're able to avoid radiation-induced lymphopenia, maybe our spurring the immune system along with the appropriate agents may result in improved survival outcomes. Of course, this is multifactorial, and there's many other aspects to be considered when thinking about lymphopenia, such as tumor-induced bone marrow sequestration, corticosteroid use, etc. But we do think that proton therapy may have a role in the setting of immunoradiotherapy. Just to touch base very briefly on IDH mutant tumors, as Dr. Fuller presented, these do have improved survival outcomes, and we are still looking at these with proton therapy. And we do have an ongoing randomized phase 2 trial, which directly randomizes to modern photons versus protons. And here we are looking to, again, reduce side effects and improve cognitive function in these patients with low-grade tumors, which may not have cognitive impairment, large cognitive impairment at baseline, but could be subject to radiation-induced cognitive impairments over the course of their life. So in summary, photon therapy really does remain standard of care for glioblastoma. However, we and I do believe that there's still great promise in proton therapy. I think we have the potential for improved disease control by two different means. One is potentially dose escalation, giving more dose to the tumor and getting rid of that low dose spread. But I think even more so, perhaps in reducing radiation-induced lymphopenia, especially in the setting of immunotherapy. Thank you for your time. I'm always happy to answer questions or share my thoughts. And with that, I'll stop sharing my screen. Turn it back over.